Now we'll switch to depression. Now, depression has been called the common cold of psychopathology by Martin Seligman. He's a well-known researcher in depression because it's estimated that between 5 to 20% of people will experience a major and incapacitating bout with depression during their lifespan, and rates of depression have been increasing steadily in recent years. Clinically defined depression is characterized not just by feelings of marked sadness lasting 2 weeks or more. So it's not just the blues or a temporary state of being down. It is sadness that is severe enough to have a major impact on a person's ability to engage socially and to carry out his or her regular activities, including work and play. One of the hallmark features of depression is a loss of the ability to enjoy activities that were once pleasurable for a person. Sufferers of depression often feel guilt, grief, and worthlessness, and they view the world through a cognitively biased lens of pervasive and distorted negativity. It's common for them to show psychomotor, which means movement, impairment, either retardation, so every little movement requires a great deal of effort, or agitation, which is excessive movement. It's common also to have disruptions in sleep patterns and shallow sleep, in which there's frequent early morning wakening at 3:30 a.m., 4 a.m. And people who are depressed often have elevated levels of glucocorticoids. It's been shown that more women than men suffer from depression. Now, this may reflect patterns of help seeking. Women may be more likely to seek help, and in the past, it may have seemed more socially acceptable for women to seek help than men. Or this might reflect an influence of sex hormones and the circuitry in the limbic system structures that influences rates of depression. As I mentioned previously, depression has a huge impact on sleep and the sleep stages. The depressed person falls asleep faster, spends little to no time in stage 3 sleep, and enters REM for the first time much faster than a non-depressed person. And again, they often wake frequently. Interestingly, when depressed people are awakened each time they enter REM sleep, they report a significant reduction in depression. So these abnormalities in sleep patterns are thought to be related to disturbances in circadian rhythms that are related to depression. And this is consistent with seasonal affective disorder, which is thought to occur because of seasonal variations in light that disturb circadian rhythms. So what does a depressed brain look like? Here are some of the differences that are observed between the brains of depressed and non-depressed people. Depressed people have greater blood flow to parts of the frontal cortex and the amygdala, but less blood flowing to areas in the frontal lobes involved in attention. Also, the cortex of the right hemisphere has been found to be thinner, and the hippocampus on both sides has been found to be smaller than non-depressed people. Depressed people also show abnormalities in the activity and the functioning of several limbic system structures in the brain. And Davidson and colleagues found that depressed individuals show more activity measured by EEG and functional MRI in the right frontal hemispheres compared to the left than non-depressed people. And you'll recall that this is consistent with what he found for the experience of negative affect, negative emotion. Those individuals who are experiencing negative emotion also show greater right frontal than left frontal activity. So what are the causes of depression? Well, research involving twins has shown that genes play a significant role in who develops depression. But even though it's a significant role, it's not a strong influence. And the genes that are involved have yet to be conclusively identified. Other influences, environmental factors, have been shown to be important. Higher rates of depression and mental illness for children whose mothers were pregnant during the Dutch hunger winter in World War II suggest that prenatal factors may also play a role in the development of depression. It's possible that they create a vulnerability to the disease. Robert Sapolsky also points to stress as a major contributing factor. Stress has been shown to be a trigger for depressive episodes, And as I mentioned before, depressed people often have higher rates of glucocorticoids, specifically cortisol. Sapolsky argues that it's impossible to understand either the biology or the psychology of major depression without recognizing the critical role played in this disease by stress. Other theories of depression have identified potential biochemical causes. One of these is the serotonin hypothesis. The serotonin hypothesis suggests that depression is a result of not enough serotonin available in the brain. So drugs such as selective serotonin uptake inhibitors, SSRIs, which you are no doubt familiar with by now, work to slow down the reuptake of serotonin in the synapses, leaving more of it in the synapse to keep sending the message to the postsynaptic neurons. And this helps to overcome a shortage of serotonin. So an SSRI you've probably heard of is Prozac. So Prozac works by stopping the serotonin transporters on the neurons that actually grab the serotonin and suck it back into that presynaptic neuron to be packaged up into the vesicles and used again. So a lot of people who have depression have been helped by SSRIs, but it doesn't work for everybody. And the serotonin hypothesis has been tested many times, but the results are inconclusive. So many studies haven't found that depression is related to having enough serotonin. And other drugs like Wellbutrin, another antidepressant, which increases the amount of dopamine and other neurotransmitters in the synapse, such as norepinephrine, have also been shown to relieve depression symptoms. Another problem with the serotonin hypothesis is that there's often a lag of several weeks between the time the patient takes the SSRI and when the depression symptoms begin to abate. And sometimes patients even feel worse before they feel better. If the problem is simply too little serotonin, then the temporary worsening of symptoms as soon as more serotonin is available doesn't quite make sense. There's one additional, more troubling issue with SSRIs to treat depression, and that's that the use of SSRIs for children and teens for depression is related to higher rates of suicide while taking those drugs. So others have suggested that it's not just serotonin levels that lead to depression, but other monoamine neurotransmitters as well, including norepinephrine and dopamine. Using this idea, treatment is focused on reducing the amount of the enzyme that breaks down all of these transmitters in the synapse to inactivate them so they don't continue to bind with receptors and stimulate the neurons. So you'll recall that the way the communication between neurons is stopped at the synapse is either by reuptake of that neurotransmitter that's communicating across the synapse or by breaking down that neurotransmitter in the synapse by an enzyme. So the enzyme in this case would be monoamine oxidase because it would be breaking down the monoamine neurotransmitters. And in fact, drugs that were designed to stop the action of the monoamine oxidase enzyme were the first antidepressants. One really interesting fact about antidepressants in the treatment of depression is that their use has actually been shown to grow or regenerate neurons in the hippocampus of depressives, which has been shown to be atrophied. So when they take SSRIs and antidepressants, the hippocampus actually becomes larger, actually increases in volume. And if you give those individuals a drug that blocks the growth of new neurons, also called neurogenesis, from happening, the improvement in depression is also blocked. Now, other than drugs, there have been more radical treatments for depression, such as electroconvulsive shock therapy, or ECT. In ECT, the person is anesthetized and muscle relaxants are given to avoid injury from seizures that result from the electricity applied through the electrodes on the head. The exact mechanisms that make ECT an effective treatment are not known, but it's thought that it increases individuals' responsiveness to dopamine and norepinephrine. And it also appears to stimulate neurogenesis, or the growth of new neurons in the hippocampus, just like antidepressants do. So another promising treatment for depression that is less painful and less invasive comes from a relatively new technology in neuroscience called transcranial magnetic stimulation, or TMS. And this uses magnetic fields to stimulate nerve cells in the brain. So it involves placing a magnetic coil, shown in this picture that looks like a sideways number 8, near the scalp and using an electromagnet to create magnetic currents that stimulate neurons. Now, these magnetic currents can last anywhere from a few seconds to 90 minutes, and they stimulate those neurons. It's painless, and it doesn't require surgery or anesthesia, and it has been shown to be an effective relief from depression. Studies that have investigated this have applied TMS to the frontal lobes, both the left and the right frontal hemispheres. Both have been shown to relieve depression symptoms. It doesn't matter which side the magnetic stimulation is applied to. Ketamine is another very newly developed treatment for severe depression, especially depression that is drug resistant. It's a veterinary anesthetic that actually is known as Special K as a street drug. But injections of ketamine have been shown to relieve severe depression in a matter of hours. And it's thought to do that by targeting glutamate in the brain. Another interesting depression treatment is deep brain stimulation, and that's when a surgically implanted electrode, or more than one electrode, in the brain is attached to a pacemaker-like device that delivers small pulses of currents to parts of the brain important in depression. So one of the places that electrodes are being tried out is in the cingulate cortex, just above the thalamus. And this is a place that is thought to inhibit sadness. So they've put electrodes in that part of the brain and stimulate it, and they've had success in treating depression. And it's thought that the success is because stimulating that part of the brain tells the brain to stop being sad. One recent study found that deep brain stimulation in the cingulate cortex was effective for 60% of the people with drug-resistant depression. And with the other 40%, they speculate that they just may need to find another area of the brain that needs to be stimulated to have that kind of success. Cognitive behavioral therapy has also been shown to be an effective treatment for depression, and especially when it's used in conjunction with antidepressants such as SSRIs. And finally, a last treatment for depression that is simple, relatively painless, and free, and that also has been shown to be as effective as antidepressants, is exercise. Studies have found that a 30-minute brisk walk or jog 3 times a week produced relief from depression symptoms that was equivalent to taking antidepressant medication. So I left off part 1 with a mood disorder that's related to depression called bipolar disorder. Bipolar disorder used to be called manic depression, and it includes cycling between depression episodes and manic episodes. And a manic episode, or mania, is a distinct period of abnormally and persistently elevated, expansive, or irritable mood. So the person who's experiencing a manic phase or a manic period is a person who has inflated self-esteem. They have really little need for sleep. They talk excessively. They're very distractible. They have racing thoughts and ideas, and they have excessive involvement in pleasure-seeking activities. So originally, I was going to give you some examples of things that somebody in a manic episode would say. But I thought it would be more interesting if you actually saw him say the things himself. So here you go.
Charlie Sheen has got to be on drugs again.
Sure. Yeah. Yeah, I am on a drug. It's called Charlie Sheen. It's not available because if you try it once, you will die. Your face will melt off and your children will weep over your exploded body. Too much. So it's just I woke up and decided, I've been kicked around, I've been criticized, I've been like the aw shucks guy with like this bitch in rock star life, and I'm just finally gonna completely embrace it, wrap both arms around it, and love it violently, and defend it violently through violent hatred. You're dealing with a Vatican assassin. Sorry. What does that mean, you're wondering? Whatever, it's just a joke. People take everything so literally. How about I tell them I'm a high priest, Vatican assassin warlock. I'm Hitler, you know what I'm saying? Come on, man.
And what does that mean?
I don't know.
Where do these words come from,
All
Charlie?
those words that sound cool together. It comes from my grand wizard master. I don't know, man. Stuff just comes out, and it's entertaining, and it's fun, and it sounds different than all the other garbage people are spewing, you know?
You have millions of fans.
I have billions of fans.
Billions of fans.
Sorry.
Tell me about the last time you took drugs.
Last time I took drugs, I probably took more than anybody could survive, you know?
What are we talking about? How much?
I don't know, man. I was banging 7-gram rocks and finishing them because that's how I roll. I have one speed. I have one gear. Go.
How do you survive that?
Because I'm me. Because I'm me. I'm different. I just have a different constitution. I have a different brain. I have a different heart. I have a different, I get tiger blood, man.
You're proud of that party moment?
Of course. Why wouldn't I be?
Drugs?
No,
Why would you be?
Because I expose people to magic. I expose them to something they're never otherwise going to see in their boring, normal lives.
So that gives you an example of what an individual is like when they're in that manic phase. In bipolar disorder, the depression phase is the same as with regular depression. Now, regular depression has also been called unipolar depression. Bipolar disorder is much less common than depression, and it appears to be very strongly genetic. There's no sex differences in rates of bipolar disorder, so men and women develop this disorder relatively in equal rates. The most effective treatment so far has been lithium, and lithium is thought to act on the neurotransmitter norepinephrine. Lithium also appears to promote neurogenesis in the hippocampus, both hippocampi, of bipolar patients. One final note, it is possible to have unipolar mania, just like unipolar depression. So there is a cycle between manic episodes and periods of relatively normal mood. Here's an example of functional brain imaging for one person during a manic phase and that same individual during a depressed phase. So in this image, white indicates the greatest brain activity, while blue indicates the lowest. So you can clearly see that during the manic phase, there appears to be hyperactivity in the brain compared to the depressed phase.